Good morning, everyone. This is Scott Adams, publisher of Repertoire magazine. We're going to give it about 1 minute, and then I'll do an introduction of our speaker today, and we'll get started. So about 60 seconds. We still have some people coming into the webinar. Okay, let's get started, everyone. Again, this is Scott Adams with Repertoire magazine. Thank you for joining us today. I want to start out with just saying a few words about our sponsors. Supermax Corporation, which is a leading international manufacturer, distributor, and marketer of highly quality medical gloves, established in 1987. Its founder started the trading business to distribute latex gloves and eventually ventured into manufacturing exam gloves for healthcare settings in 1989. I'd also like to thank PDI. PDI is an international leader in reducing preventable healthcare associated infections through 3 common interventions: hand hygiene, environmental disinfectants, and skin antiseptics. Thank you, both of you, for helping to sponsor this so that we can move quickly to get our speaker today, Dr. Hudson Garrett, Jr., on the phone. And now I'd like to introduce Dr. Garrett. Dr. Garrett is Vice President of Clinical Affairs for PDI. He is recognized as an expert in infection prevention and control across the continuum of care. He has completed the Johns Hopkins Fellows Program in Hospital Epidemiology and Infection Control and the CDC Fundamentals of Healthcare Epidemiology Program. He also serves as an industry liaison for the Association for Healthcare Environmental Board of Directors and is the lead faculty member of Infection Prevention Essentials online course. In 2013, Dr. Garrett was honored as the Who's Who in Infection Prevention and Control by Infection Control Today magazine. With that, I'd like to turn it over to Dr. Garrett. Thank you so much for being here. We'll take questions at the end, and you can send in questions as he's going through his slides this morning. Again, thank you.
Perfect. Thank you very much, Scott. And thank you for taking the time out of your busy schedules to participate in today's webinar. I did want to start with a quick disclaimer that due to the changing and evolving nature of the information on this virus, like any other emergency virus, we would always refer you back to the CDC or the World Health Organization for the most up-to-date information. All the information that we're presenting in today's program is current as of last night, and we'll continue to update this information as necessary. The quick objectives of what I'm going to discuss today, and I don't anticipate the actual webinar will last more than about 30 minutes, and then we'll leave ample time for question and answer, and we appreciate those of you who have already sent in questions in advance. I first want to start with talking about the origins of the Zika virus, and specifically the routes of transmission, which is where a lot of the public fears come in. We'll also talk about how Zika is going to impact the healthcare continuum of care, especially inpatient and outpatient settings, and then finally we'll finish with the CDC recommended steps to reduce the risk for transmission. I think first we need to start with what is Zika virus, and then we'll talk about the symptoms. The Zika virus itself is not necessarily a new virus. It is a mosquito-borne, what we refer to as a single-stranded RNA virus that's very closely related actually to dengue virus. We do see this transmitted by a particular type of mosquito. This mosquito, and this is important to note, is also found here in the United States, the continental United States. So it's not just a South American problem or a Mexico problem or tropical location. We do have this exact same mosquito species here already in the United States. What's interesting about this virus is that many of the patients that actually become infected are actually totally asymptomatic. So they don't show any signs of being ill at all. So only 1 out of 5 people are symptomatic to the point where we know that they actually have the virus and can really detect it quickly. The common symptoms, and this is where it becomes problematic, are very similar to things like yellow fever and dengue fever, as I mentioned before. So you look at, you've got fever, you've got rash, joint pain, conjunctivitis or red eyes, and muscle pain and headache. this can really be very similar to many other conditions, even some of the things like influenza, which of course we're seeing right now is on the rise here in the United States. The other thing that's a little bit unknown from a microbiology standpoint is the incubation period. You know, how long is someone potentially carrying this before they become infectious? And we estimate that the incubation period is a few days to a few weeks, but we're still learning more about this. And we have some of those talented experts at the CDC working on this around the clock as we speak to better define the incubation period, because that will help us from a transmission prevention standpoint. So how is the actual virus transmitted, and how do we diagnose this? Well, what's interesting about this is the virus itself is transmitted through the bite of an infected mosquito. So there's a lot of misinformation in the media that says the mosquito itself just randomly carries the virus, and that's simply not true. The virus does come from the infected, or the mosquito, should I say, becomes infected by the blood of an infected person. So when it bites someone that has the virus, it then can carry that to the next person. We find that most of those mosquitoes actually are aggressive daytime biters, and they will bite you both indoors and outdoors. So this is not simply an outdoor-related problem, but we do also see that there's some biting that is taking place at night. And where the, I guess, fear has come in is the transmission from a pregnant mother to her fetus around the time of pregnancy. So the diagnosis, as I mentioned before, based on the symptoms, can be very challenging for healthcare providers. And this is very similar to what we saw with Ebola virus disease, where the symptoms were, quite frankly, very similar to other conditions that we already see on a regular basis. The other thing that we're learning is more about the diagnostic testing, which I'll discuss in more detail in a future slide. But we are seeing the deployment of the rapid testing kits at the state levels. So the CDC has worked very aggressively with state health departments to deploy these actual testing kits so that we can get real-time rapid results and then confirmatory testing at the CDC National Laboratories in Atlanta, Georgia. So this is actually an image that was provided by CDC of the specific mosquito. And again, this mosquito is already found in the continental United States. However, we have not seen any local transmission of the virus here in the continental U.S. in some of the tropical locations. This is a map of the current outbreak zones. This was at the current map that they have updated from February 8th, and you can see that it's fairly widespread transmission, and especially our colleagues down in Brazil and other South American countries, Mexico certainly, U.S. Virgin Islands, and Puerto Rico have been hit pretty hard with this, and we expect to continue to see this to grow. The current World Health Organization estimates really are calling for several million cases worldwide of this particular virus over the next few months. I did want to specifically talk about some of the current case counts, as we refer to them, for both the U.S. as well as U.S. associated territories. Currently, we're seeing about 35 travel-associated cases of Zika virus disease here in the continental United States. And just for clarification, travel-associated does not mean localized transmission, so we're not seeing human-to-human transmission here in the United States. These are people that made travel plans, went outside of the country to affected areas, and returned with positive cases that have been confirmed via the laboratory methods. We have not seen any locally acquired vector-borne cases, so we're not seeing anything that's going back and forth. And you can see a listing of the states there. And again, this will continue to grow. This is not something that's going to be limited to only certain states. If we look at the U.S. associated territories, specifically Puerto Rico and the Virgin Islands, we've seen 9 locally acquired cases and 1 travel-associated case for obvious reasons. I did want to show a quick picture, which is pretty cool, of the electron micrograph of the Zika virus that was, again, provided by CDC. And this virus is not something that is totally new to us. We've seen this very similar to like Ebola. We have seen the virus in different places throughout the world, but we really haven't seen widespread outbreaks like this, and certainly not the amount of microcephaly infants that have been born, which is certainly a big tragedy for the mother and the entire family. I want to talk now about routes of transmission. So, what is the biggest route of transmission, and especially one of the things that's been in the news lately is the sexual transmission. Since it is a vector-borne, we know that mosquitoes can certainly be a route of transmission. We have certainly documented that the mother-to-fetus transmission, sexual intercourse, and this is something that we're still learning more about, where perhaps, let's just say the male goes to an affected area, comes back and is completely asymptomatic and has sexual intercourse with his partner, and they do not use protection. There is potential transmission there that we are investigating. And then blood transfusions are a new one. There is a lot of work going on both with the CDC, the World Health Organization, and of course the US FDA that regulates the blood supply, looking at some safeguards that can be put in place to make sure that we're testing for this in the blood supply, because in South America they've had several cases that have been transmitted, believed to be through the blood supply. And the most recent evidence is looking at saliva and urine, where we've seen confirmatory testing where the virus is present in these body substances. And again, I go back to the lessons that we learned from Ebola, where there are certain body substances that historically, from an infectious disease standpoint, we did not consider problematic. Things like tears and urine and saliva. And so this is just yet another wake-up call to look at the viral transmission routes that we see for some of these emergent pathogens that are coming throughout the world. There are other conditions that can make the diagnosis of Zika virus disease very, very troublesome for healthcare providers. And you can see a listing of other conditions that have very similar symptoms. And so laboratory testing is going to be very important, as well as obtaining a good, solid travel history for the patients that might have come back from affected areas, or frankly for people that may be completely asymptomatic that are trying to get pregnant. It's important to really look at what is that travel history for a variety of different things. And again, think about what did we learn from Ebola, asking better questions of our patients, making sure they're spending the time to understand their travel history. When did they go? How long were they there? Were they outdoors? Did they experience any symptoms? And this is good for a lot of infectious diseases, not just the ones that we're talking about today. The CDC has declared Zika virus disease as what we refer to as a nationally notifiable condition. This is quite a big deal because it adds it to the list of conditions that are reportable by public health law. And so these are reported by the state health departments as well as local health departments to the CDC, so that we can really get a real-time assessment of how many cases are taking place in the United States. It gives us an idea of the burden of the disease, and it's also something that we are really bringing in the experts. Many of the experts from CDC's Colorado location have been relocated temporarily to Atlanta to really study this and provide the expertise that they have. And I'm very, very confident in colleagues at CDC and their work that they're doing to really help us not only better understand the transmission, but also come up with the best possible mitigation strategies to, eliminate this as much as possible. Any suspected or confirmed cases would be reported to the local or state health departments, and then laboratory confirmed cases are reported through an electronic surveillance system that we call ARBONet, and that gives us, again, that real-time surveillance, which is what you're seeing on the CDC website as well as the news media. So, especially with pregnancy, and this is probably the biggest issue and rightfully so, is that there's this potential for babies being born with microcephaly, where they have some abnormalities, of course, of the head. The head size is much smaller compared to an infant with a normal head, and this can lead to permanent birth defects and potentially death. And so, this is something that can be completely traumatic, as we can imagine, for the families associated with this. And particularly in Brazil, we've seen thousands of cases where, unfortunately, babies have been born with this condition. We're still really learning more about Zika virus disease as it relates to microcephaly, but we do feel very strongly that there's a good epidemiologic connection between the actual virus as well as, unfortunately, this birth defect. The CDC's put out some fairly aggressive suggested recommendations for pregnant women, particularly to protect women, especially those that are asymptomatic, and there's been some updates that just came out this week. Particularly if you think about how the virus can be spread, we know that it can be spread from the pregnant woman to her unborn baby, and particularly with the birth defects, we really want to look first and foremost at people postponing travel to these affected areas. And we've seen, many organizations that might have events that are going there, relocating. Certainly the CDC is working very closely with the affected areas. And I believe last I checked, CDC has over 50 to 60 employees on the ground in these various areas, working with federal government as well as our local U.S. territories such as Puerto Rico to help us reduce the risk for transmission. Anytime a pregnant woman might consider travel to these affected areas, it's important to talk to their healthcare provider and really have a candid conversation about the risk associated with that, and also think about your male partners that might either travel to or temporarily live in areas with ongoing transmission. The general recommendation is either abstinence or certainly using protection in the form of a condom. And one of the challenges that we're facing right now is how long does the virus live in body fluid? We've seen it found in semen for several weeks at a time, and we're not definitely sure what the actual time that it can survive in those fluids necessarily is, and so that's why you see some of these recommendations. And if a woman is trying to become pregnant, it's also important that they consult with their healthcare provider prior to going to these areas. And it's very rare for CDC to issue travel alerts. And I am extremely pleased to see the aggressive stance that they've taken on this to really protect the interest of public health. In addition, they've released some more specific recommendations that I thought would be helpful to go over today. We'll start with asymptomatic women. So if we have an asymptomatic pregnant woman with no symptoms and they've gone to areas that have ongoing transmission, it is a good idea to offer testing upon return. The CDC current recommendation is 2 to 12 weeks after return from the travel. And women that have clinical illness that does be, it's kind of indicative of Zika virus within either their travel time itself or within 2 weeks of travel afterwards, they should also receive the serologic testing. And we'll talk about what that looks like here in just a second. For women that actually reside in those areas, either temporarily or permanently, we would want to make sure that that testing was offered during the first week of actual illness. And again, we go back to those symptoms. It's better to do the test and make sure that this virus is not present than to not do the test and just sort of rule out symptoms based on something else. The other recommendations include really discussing reproductive life plans. So again, having a candid conversation with the OBGYN provider, really looking at the pregnancy and the timing of it, and also looking at potential risks. Maybe the mother, for example, has other health-related issues that could be problematic just in general. And so it's important to discuss that travel history and really look at that during the history and physical. I know several of you have asked about laboratory testing. There is not currently an FDA-cleared commercially available test that we have. I certainly think that that will change, and I know CDC is working aggressively with the National Institutes for Health as well as private manufacturers to try to develop that type of testing. But we do have testing that's available through CDC and public health laboratories, which is really a reverse transcriptase polymerase on the serum. And there's also some neutralization testing that can be performed to specifically look at the amount of virus present and also try to differentiate it from other viral illnesses. And I mentioned before, there's other viruses that are very, very similar to this. So having these laboratory tests are very, very helpful. When we look particularly at people that are pregnant, amniocentesis is a new part of the recommendation, and it's something that should be offered to pregnant women. So it's not a mandatory thing, but if you look at the CDC guidance, it's really a personal decision that's made by the healthcare provider as well as the woman. But if you have a pregnant woman that has recent travel with ongoing transmission, and they're reporting 2 or more symptoms when they come back, it's important to really look at this as a potential recommendation. It's not recommended until after about 15 weeks of gestation, and it should be based on the healthcare provider's conversation and looking at the total picture. But if you do see a positive test result that came back from amniotic fluid, typically that would be suggestive of an intrauterine infection of Zika virus disease. And at that point, again, there's no treatment that's available. So what does the CDC recommend for mitigation? Well, there's some basic things like using bug spray, and particularly they suggest using an EPA-registered insect repellent that contains DEET. There are a lot of questions about the use of DEET, specifically for children. It has been proven widely effective and safe for use in children. You don't want to go under 2 years of age, and CDC has some recommendations about that as well as FDA. And you also want to not apply it directly to the face, rather use your hands and apply it in a safer motion. The other thing that we can do, too, is really wear appropriate clothing and stay indoors. Again, these bugs are not something that just bite outside. They do bite inside as well, so keeping screens on. Air conditioning is very helpful. You don't want to leave windows or doors open, especially in areas where there's ongoing transmission. And if you're going to have to travel, and again, the CDC recommendation is to consider postponing travel, but we understand that there may be instances where you have to travel. It is a good idea to have a proactive conversation before you commit to that with your healthcare provider and get any recommendations that he or she might have before you go to these any affected areas. And last but not least is there is available clothing that can be treated with a permethrin spray, and you can purchase this online on sites like Amazon, or you can certainly just Google it in general. Local sporting goods stores also carry this, and it's a great idea to use that. The nice thing about spraying and the gear down or your clothes with it is that it lasts for several laundry cycles. And so it really helps. It's more like a stronger bug repellent. The CDC has issued interim guidelines for the prevention of sexual transmission of Zika virus disease. So far, we've seen 3 documented sexual transmission incidences to date. This is not something, honestly, that we thought we would see. And so, again, we're learning a lot more about this virus as we go. but the virus has been found to be isolated from the blood about 2 to 10 weeks after illness onset and found in semen even longer than that. And that's why you see the recommendation for the use of condoms or abstinence. And because many of the people, again, 4 out of 5 are asymptomatic, they don't have any symptoms, it's important to maintain the use of condoms. There are recommendations for men and their pregnant partners, and especially when we see a man that's gone to an affected area, maybe returns asymptomatic, and is going to have sexual intercourse, it's a good idea just to be safe and either maintain abstinence or, again, use a condom. Pregnant women should actually be very aware of their male partner's potential exposures. So understanding where they're going, are they going to be outside? Do they use bug repellent? Do they have any symptoms? These are all things that are important family conversations to have that we need to really also advise our healthcare providers of as well. When we look at treatment or prevention in general, unfortunately there is not currently a vaccine or a cure or specific treatment for this particular disease, and this is very similar to what we see with other things like Ebola. But we do have some good news on the horizon. The National Institutes for Health has announced as of last week that they are really accelerating development of a vaccine that would be commercially available for widespread use for those that might be at high risk. They estimate that this vaccine will be available in the next 2 to 3 years, which is quite unheard of as far as the rapid nature of that. And they're working closely with partners at the FDA to develop vaccines that will be safe and effective and accelerate that through the clinical trials process. We do not, as I mentioned, have any current treatment available. So there's no magic bullet, there's no antiviral therapy that can be given. And so it's really mostly supportive care. We know that these people can become dehydrated, certainly very tired. The joint pain can be treated, with certain painkillers. You do want to stay away from aspirin or NSAIDs because of the risk of bleeding. And certainly it's important to get plenty of rest. And so, when you think about if you're a patient that contracts this, there's not a lot that we can do other than be supportive. And so that can be very problematic for patients that, want a pill or a medication or a vaccine that can make them feel better much faster. So it's very similar to the common cold where we have to let it kind of ride out. I did want to point out the current CDC travel restrictions that are present, and you can see the list is extensive here. I totally expect that this list will grow. And so you can see everything from the Caribbean to Central America, certainly Mexico, and South America has been hit particularly hard to the point where they're really deploying the Army in some places to eradicate mosquitoes. And I will say that that's one of the big premises that CDC particularly is taking is how can we eradicate these mosquito populations that might be potentially infected. And that is really the best course of action. And I know it sounds very elementary and basic, but it's a great way to start to eliminate this viral transmission. There are a couple questions that have come in specifically about other general infection prevention and control recommendations. And hand hygiene should be performed as indicated by the CDC or WHO guidelines. And you do want to use an EPA-registered disinfectant for your high-touch surfaces and personal protective equipment as indicated by CDC. I do want to say, though, that there is no specific hand hygiene agent, EPA-registered disinfectant, or skin antiseptic for that matter, that has a claim for Zika virus disease or Ebola virus disease for that matter. And so the reason I point out those recommendations is that there's really nothing special we have to do from a general infection control and prevention standpoint at this time other than general recommendations. Again, the virus is spread through the body fluids that I mentioned before, but we're still learning more and more about it, but there's no need to change any of the things that you currently are doing. I know one of the questions that's also come in as we open up for Q&A is, if you have several long-term care facilities have asked about resident activities outdoors. And, this is definitely something to be concerned with. And what I would suggest is certainly applying bug repellent to the residents and look at, can you move the event indoors or can you provide bug lamps or things of that nature? Because if you can really try to eliminate or knock down the presence of mosquitoes, you're not going to have a problem. And so there's some very good basic prevention mechanisms that we can put in place with some great products that are EPA registered and contain DEEP that will certainly help us out. So with that, I will stop and then turn it back over to Scott for questions and answers.
Thank you so much. That was excellent information, and we have received a handful of questions throughout the webinar, so I want to touch on those briefly. You hit on a lot of them, so you can kind of skim through some of the answers, Dr. Garrett, but one of the first questions we got was, should we do anything special around hand hygiene currently?
So the answer is no. This is not something that we're worried about as far as hand hygiene transmission. You still use your regular, FDA product, alcohol-based hand rubs. There's nothing different that you have to do.
Next question that came in: do you know when the vaccine will be available for commercial use?
Sure. The NIH estimates that virus will be available in the next, the vaccine for the virus will be available in the next 2 to 3 years. Of course, that's dependent upon FDA approval.
Here's another one. How long do symptoms last? Once symptoms are resolved, is it still possible to transmit the virus to others?
The actual virus can stay in the body for several weeks at a time, we estimate. So the symptoms typically don't last more than a week. What we are advising is if you are testing positive for that, especially for sexual intercourse, that you do use, follow abstinence, use a condom until they learn more about the specific incubation time period as well as how long it can really live and be transmitted. So that's more of an unknown at this time.
Is it an enveloped or non-enveloped virus?
I'm sorry, could you repeat that?
Yeah, the question was, is it an enveloped or non-enveloped virus?
It's a single-stranded RNA.
And then, let's see, we got a couple more here that just came across. Here's one. It says, we know that dengue, Zika, and yellow fever are spread through mosquitoes, but Zika transmission has more, and to not just be a vector or mosquito transmission, but we now have potentially sexually transmitted cases, and just last week, possibly cases and stains in urine and saliva. Can you comment on other bodily fluids and also people-to-people transmission?
So the risk of general people-to-people transmission is very, very low. And I want to say that a second time for obvious reasons. The risk for people-to-people transmission is very low compared to other viruses. If we compare this to flu, for example, it's night and day difference. What we do know is that there are other substances, as you mentioned, urine, saliva, that we are evaluating scientifically to look at what's the risk for transmission from those. And I will say that if we go back to Ebola, what we learned compared to what we thought we knew, we continue to learn more about these viruses. So it would not surprise me if we saw documented scientific evidence of transmission from some of these things. So again, the way I always tell people and educate folks is if it's a body substance and it's not yours, then you need to treat it as not yours, and you need to take the precautions necessary by wearing personal protective equipment to protect yourself and follow standard precautions, and that'll give you your best chance of success.
Yeah, that leads right into the next question, and actually I'll make this the last question of the day in respect of everyone's time. Should medical device manufacturers plan for increased demand of disposable items such as thermometer, probe covers, or blood pressure cuffs?
I would probably say no, in the sense that, again, we're not worried about Zika virus really being transmitted via the environment like that. So it's not going to be anything different. What I would say is you may see an increase in use of point-of-care testing for things like influenza and other, I guess, diseases that might have similar symptoms. But I really wouldn't necessarily anticipate an increase in the use of disposable type products for vital signs and things of that nature at this point.
Okay. Dr. Garrett, thank you so much. Thank you to the close to 200 people who called into this webinar this morning. We will be posting it and hosting it so that you have access to it and others within your organization have access to it. In the near future, we'll do that via the Daily News and a few other Repertoire/JHC outlets. Again, thank you so much to the two sponsors, PDI and Supermax, and we wish you all a very pleasant day and have a great weekend. And again, Dr. Garrett, thank you so much for being on the call.